ladies and gentlemen, dear colleagues. I'm delighted for the opportunity to discuss some hurdles with you in anticoagulation therapy tonight, and I'm very grateful to the organizer for this opportunity. In fact, I have a long history of anticoagulation research, and this by nature means also that you have collaboration with industry when it comes to development of anticoagulants. In fact, the journey started with the heparins in the 80s, and then we had the low molecular heparins, that time as new compounds on the market, and everybody was complaining how expensive these were when compared to unfractional heparin. So we have the same complaints now with the new oral anticoagulants. Of course, these compounds are more expensive when compared to warfarin, but you also hopefully will depict very quickly then that we have safer and more convenient and more efficacious drugs available now. So these are my disclosures. I also want to bring you my best greetings from Munich, the place where I work and live, and this is the agenda I have prepared for you for tonight. In fact, the first hurdle I thought is focusing on dosing regimen of the NOACs. It may be a hurdle for some people because not all of us may have understood the rationale for dosing regimens, for example, for VTE treatment, where we have, for example, twice daily dosing in the beginning, followed by once daily. And the rationale for dosing regimen for stroke prevention in AF, where, for example, we have compounds on the market with once daily dosing and others have twice daily dosing. The next hurdle is then how to use these new oral anticoagulants in clinical practice. Practical use is crucial. We must ensure safety and efficacy by using them, and in particular when it comes to bleeding, another hurdle may be how to stop bleeding, how to manage bleeding. So what makes new oral anticoagulants different from other conventional anticoagulants? Well, first of all, they are oral. This is not new because also vitamin K antagonists are orally available. However, the new compounds have a wider therapeutic window. That means they are a bit more forgiving with regard to dosing. We do not need routine monitoring. These compounds have the predictable mode of action. They have much lower risk for food and drug interactions when compared to warfarin, and they have a fast on and offset of action, and again, this is in contrast to the vitamin K antagonists such as warfarin. We do not need to bridge the patients anymore when it comes to surgery or other interventions. No need for bridging with heparins in case of interventions. That is, I think, a major advantage, because at the final end, when it comes to bridging, you may realize my talk is then finally over, but I will take you back to the bridging procedure with conventional drugs. It sometimes is a nightmare when patients are on warfarin and need to undergo interventions. So these are 4 compounds listed here, 3 of them worldwide being on the market. Well, in fact, edoxaban, a Japanese 10A inhibitor, is also on the market in Japan for primary prevention of VTE, but not yet for the other indications. But all of them have been developed beyond VTE prevention for VTE treatment and secondary prevention and stroke prevention in AF. And rivaroxaban is the only one so far having been developed for secondary prevention in ACS patients, not yet on the market in South Africa, but on the market already in some other countries. So now we have many indications, different dosing regimens for the same anticoagulant. And my question to you, is it an advantage or rather more a confusion? I wasn't here if I wasn't fully convinced that it is an advantage We simply need to understand which dosing regimen is good for which patient. So bringing the right medication in the right dose to the right patient. That is crucial, and that is the driving message for our session tonight. For the sake of time, I would like to limit my elaborations mainly to the different dosing regimens of rivaroxaban. Let me start at the end with the indication which is not yet here on the market, with a 2.5 milligrams twice per day for secondary prevention in atrial fibrillation. And you may easily realize that is a fourfold lower dose when compared to the 20 milligrams once per day for stroke prevention in atrial fibrillation. Keep in mind, this has been developed and will be administered on top of dual antiplatelet therapy. That's why there is a low dose, because in this indication, I will discuss it with you in a few moments, we are talking about arterial thrombosis, because these clots are rich in platelets as they occur in the coronary arteries. And here in SPAF, we are talking about the venous type clots, which will be seen on the next few slides. So you see 4 indications, 4 different dosing regimens, and we can say this compound, as also others, but this compound in particular has been developed based on the pharmacology, the pathophysiology of the underlying diseases and the patient's needs. So you will then see why we have even different dose regimens in a different dosing regimen in the same indication. There is a rationale behind and also a history behind. So these are the dose regimens. Again, once daily for VTE prevention, once daily for stroke prevention, however higher dose, prophylactic dose, double dose once per day for patients who have normal renal function. If renal function goes down, the patients should receive the lower dose, 15 milligrams, again once per day. And here you see for VTE treatment, for the first time, we have 15 milligrams twice per day, up to 3 weeks, to replace low molecular heparin in high dosing regimens. That is the reason why here you have an intensified dose regimen up to 3 weeks, followed again by the maintenance dose regimen once per day, 20 milligrams. And we mentioned already the ACS with the twice daily 2.5 milligrams. And as with any anticoagulant, we have the need to balance with risk of bleeding, and that's why we have very low doses here, and the patients can tolerate higher doses in the other indications, as it is the case also for any other new oral anticoagulant, including the dabigatran, apixaban, and in the future also edoxaban. So just spending one more minute with pathophysiological considerations, I would like to point to the difference again between arterial clots and venous type clots. Arterial, rich in platelets, venous type clots, as we also have them in atrial fibrillation patients, clots formed in the heart, in the appendage. We have fibrin-rich clots here and there. These are large clots. Arterial clots in the coronary arteries are small. We have a rapid onset of clot formation here, the slower onset in the venous type clots, and we have antiplatelets as modalities of choice in the coronary arteries, whereas we have anticoagulants here and anticoagulants there, and you can easily see that the anticoagulants given in both indications is warfarin, and if you give warfarin, it's the same dose as if you gave it for secondary prevention in VTE patients, or primary prevention of stroke in AF patients. So I would like to finish with that, saying that in arterial clots we are talking about high shear rates leading to platelet activation. In AF and in venous clots, talking about low shear rates leading to activation of coagulation, and that's why we have the anticoagulants in first place in these last two indications. So now leading into the field of VTE treatment, conventional treatment, we have the three phases of the disease, acute disease, phase, and intermediate and long-term disease. How do you start treatment of either deep vein thrombosis and or pulmonary embolism with conventional anticoagulant therapy? Thanks. Both. Low heparin. Do we also have colleagues among us using the Arextra, the fondaparinux? No? Not really. It's also parenteral anticoagulant, can also be given. So we need a parenteral anticoagulant. Here in the past, it was also unfractional heparin, followed by low heparin or fondaparinux, overlapping with vitamin K antagonist until the vitamin K antagonist, and that is normally warfarin, is strong and active enough by itself to do the job when the INR between 2 and 3 is reached. Then you drop the anticoagulant, the parenteral anticoagulant. That is standard of care, and I'm absolutely sure that you have done it in the past. So, some companies have taken the challenge to replace both, others did not. And there is also a negative history why some companies have become scared to replace the heparin in the beginning, because one other company, it was in fact AstraZeneca, who developed the ximelagatran, a thrombin inhibitor for stroke prevention in AF early in the 2000s, but also for VTE treatment, and you see what happened. They used the same dose as they had chosen and also clinically developed for stroke prevention in AF, 36 milligrams twice per day, and they failed in the initial phase of treatment because the dose most likely was not high enough. That time, the jury was out. Is it because of a thrombin inhibitor? Thrombin inhibitor being an ideal candidate for these patients? Or is it because of the wrong dose? Most likely it's simply the wrong dose. But you see that the curves dissociate very early in disfavor of this new oral anticoagulant with regard to the recurrence rates in the early beginning of the treatment phase. The same happened with another 10A inhibitor, which was supposed to be given only once per week as an injection, and you see for PE patients it was a nightmare. The recurrent rates were steepest and highest in the early beginning of the treatment phase, and this was a no-go. This compound did not make it to the market. So having these negative experience in mind, it has become a challenge. And how can you now, or how would you then develop a new compound in this scenario with these data in mind? So we knew that we need a higher dose in the beginning, and perhaps over time we can lower the dose. However, without dose finding, it would have been a no-go. And that was the starting point of the development of the rivaroxaban for this indication. And by the way, it also paved the way for the dosing regimen in AF, because we mentioned already that in both indications, in the long run, you simply replace warfarin in the same intensity of anticoagulation, warfarin INR 2 to 3. So this can be then also be used for the long-term treatment in stroke, for stroke prevention in AF. So here the patients were screened by complete compression ultrasound to make the diagnosis of deep vein thrombosis. After 3 weeks, they were screened again with the same device, and the patients, after the diagnosis, were submitted to either conventional care, shown here, or one of these 4 doses of rivaroxaban. 3 of these doses were given twice per day, and 1 dose was given once per day. What is behind the complete compression ultrasound, I will show you that on the next slide. The bottom line here is that the primary endpoint was thrombus regression. That means the patients needed to have as a primary endpoint in this dose-finding study a lower, objectively confirmed lower thrombus burden after 3 weeks when compared to the initial ultrasound measurement. Only if the patients had a lower thrombus burden, they were allowed to be carried through up to 3 months with the same dose. Otherwise, for ethical reasons, we would have had to take the patients out of the study and put them on conventional care. So this was the aim here, to protect the patients and to see if all doses, or at least 1 dose here for the dose-finding study, was able to reduce the thrombus burden. Complete compression ultrasound means that the patients needed to be screened from the ankle up to the groin, and depending on the localization and the size of the thrombus, the patient was assigned with score points. If, for example, 2 calf veins were affected, 2 points here. If it reached up into the popliteal vein, the thrombus, another 2 points. If also the femoral veins were affected, let's say 2, 4, 6, 2, 4, 6, maybe 10 points if the thrombus reached up here. So this was the initial finding when the diagnosis was made, and the patient needed to have lost 4 points in this score after 3 weeks. That was the primary endpoint. So at least 4 points lower in this score after 3 weeks to come up with the endpoint predefined thrombus regression. The second dose-finding study, there the investigators didn't care about the first 3 weeks. They said, well, because the first data from the other study were already available, obviously the new compound is working, and they said, we don't care about the first 3 weeks, we go straight ahead from the beginning up to 3 months and have as a primary endpoint the rate of recurrent rates. The composite symptomatic recurrent DVT and or PE events were the endpoint here, the bad events. 3 once daily doses of rivaroxaban were tested here, and again, standard of care was also in place. And you see here what happened in the first study, talking about the good events, the thrombus regression, which was at least as good as standard of care. You can clearly see it here. Perhaps the back you cannot completely see because the lights are too bright. The 3 twice daily doses, which did very well, maybe even a little bit better, but at least as good as standard of care. And also the once daily dose was not too bad. And the other study looking for the bad events, again standard of care here, and you see with 3 once daily dosing, all doses with a flat dose response did very well when compared to standard of care. So this paved now the way for the next step. For the next step means phase 3 development for this indication, and also if then the dose was defined for the phase 3 development of stroke prevention in AF. So just to summarize, we are talking about similar pathophysiology clot type-wise for DVT and AF. We have the identical long-term treatment approach, anticoagulation with warfarin, target INR 2 to 3 in both indications. Evaluation in DVT treatment phase 2 studies was done for rivaroxaban, and the identified dose was then also taken to SPARF study. And here you see that the lowest given dose once per day and total daily dose was 20 milligram in the dose-finding studies. And now you have the complete history, and you know where the once daily 20 milligrams come from. It was the lowest dose. Perhaps even a lower dose could have worked as well, but has not been tested. And that is now the full history of the once-daily regimen. And it works. You see here meta-analysis of all studies available, all 4 compounds for AF patients. They have in common that they are at least good, maybe even superior, when compared to standard of care with regard to stroke prevention and with regard to major bleeding. They all have in common that they reduce major bleeding, in particular statistically significant for all of these compounds, the rates of intracranial bleedings, which is an advantage and cannot be shaken anymore because the evidence is so strong for all of 4 compounds here, regardless of once or twice daily dosing regimen. The same is true for the complete development of these compounds for VTE treatment, but here, for the sake of time, I don't go in all the details. But you have the split between dabigatran and edoxaban. Both compounds, both companies did not touch upon the heparin phase for VTE treatment. They just wanted to replace warfarin, have the heparin in place. And rivaroxaban followed then, after all data were available, by apixaban, also with a single drug approach. All companies have shown non-inferiority for efficacy, regardless of their dosing regimens, and superiority for bleeding for rivaroxaban in the Einstein PE study, and also apixaban had superiority with regard to major bleeding. However, regardless, once or twice daily dosing. Apixaban is always given twice per day, and here we have the once daily regimen. So we must see the study data as they are, but taking messages from meta-analysis doesn't make sense because you see it has been achieved with either or, and the patient populations may have been a little different. So to summarize this theoretical part of the presentation, we can summarize the conventional treatment. We talk about bridging because we overlap heparin with vitamin K antagonist. We can call it switching for dabigatran and edoxaban to come in the future also in this indication, because heparin is in place, and it's not a single shot of heparin, because heparin needs to be given in the intensified dose regimen between 5 to 10 days, and then it's very easy to replace heparin next day by the new compound, and we call that single drug approach because these 2 compounds, and rivaroxaban has paved the way in this regard. Single drug approach means that you can start with the same dose, and rivaroxaban has the intensified dose regimen twice daily, 15 milligrams, to replace the full therapeutic doses of heparin, followed by once daily 20 milligrams over time. So, just to summarize, then the phase 3 development of the Einstein studies, I would like to point to the fact that there were 2 identical study designs, but separate studies for PE patients and for DVT patients with this dosing regimen we discussed already, twice daily 15 milligrams followed by once daily compared to standard of care. And the beauty here is that for talking about efficacy, that the curves run absolutely in parallel during the first month, which had not been seen in the other 2 studies which I showed you where the dose regimens were not adequate. Principal safety outcome, again, the beauty is that there was no difference between the 2 groups, and in particular in the beginning, despite the fact that we also have here intensified regimen of rivaroxaban, could also cause small bleeding. It does not, or it did not here when compared to conventional standard of care. With regard to major bleeding, you just see even the opposite. You see that major bleeding started dissociating very early in favor of the new compound because major bleeding was significantly reduced by the new regimen of treatment. Any more questions related to, can also be related to AF, to stroke prevention, dosing, other compounds, if you have questions related to Xarelto, Pradaxa, or Eliquis to come also on the market soon.
Thanks. In our South African guidelines, which we published, we've always been asked why we start warfarin the day later or 2 days later. That's from a logistical problem because a lot of our patients are HIV positive. And if you give an HIV positive patient, start them with warfarin, don't give them a low molecular heparin, you'd get warfarin-induced skin necrosis because they have a low protein S. So we changed our guidelines. I'm sure you're aware because you're an author of our guidelines. And
well,
maybe you can tell, just to reiterate to the audience, that is a difference in South African situation where we don't start the 2 drugs concurrently. We start with the low molecular heparin and follow the warfarin, making sure the patients already had at least 1 or 2 doses of low molecular heparin because of the risk of heparin-induced, of warfarin-induced skin necrosis in HIV-positive patients.
I'm not quite sure if this rationale should be carried through.
We have good data to show why it should be, because there's a whole group of patients at the CF Jooste Hospital in Cape Town who ran out of heparin, and they were only given warfarin. And
that is the crucial point.
And
absolutely, that is a no-go. Please do not start warfarin in a patient who is not fully anticoagulated.
That's the point. That's what I'm trying to say.
Yeah.
That's the point, especially in HIV patients. It is a major, major problem. You develop marked skin-induced, warfarin-induced skin necrosis. If the patient hasn't had proper heparin, so you really need to be aware of it, just for the population here, because it's not an issue anywhere else in the world.
Well, still the question is, why you still wait 1 more day to initiate warfarin?
I'll tell you why, because in South Africa, in the government sector, to get injection or low molecular heparin is a Schedule 7 drug. So it's got to be signed by 5 consultants and the Minister of Health, whoever. And what happens in the ward, on a practical basis, is the sister goes around and she hasn't got the low molecular heparin, but she's got the warfarin. So she just gives the warfarin. So we need to make quite sure that that patient has had their low molecular heparin or heparin before they get their warfarin. And that's why we made it the next day, because very often consultants aren't there to sign the first day. And that's why we make quite sure that they can only get warfarin on day 2.
My friend, we always found consensus. Can the consensus tonight be that it's for logistical reasons, but I think you can, that if you phrase it medically, you can also say, don't give warfarin to a patient who has not received heparin before. I was just struggling about the 1 day, because that makes it a bit complicated. But as you said, maybe I didn't know that it's so complicated to get a shot of low molecular heparin. But well, you're shaking your head. It's easy.
It's terrible.
It's terrible. Is it so terrible to get a...
Well, no, in South Africa, well, in the government sector, you can't get it. I mean, it's got to be signed by Schedule 7.
Yeah, that's true. If this is the case, then leave the guideline with this phrasing in place. But I was hearing that you said the necrosis of warfarin. You're absolutely right. Warfarin alone is a no-go. And the second we have done over the last 10 years, that we do not start with a very high doses of warfarin. We do it in the smoother way, not the very high doses, despite the fact that the patients are heparinized. So take a little longer time and you can avoid these skin necrosis.
Can I just come to the basics? I think the initial dose of warfarin was given day 2 also, from PBT, was because we were using standard heparin. And standard heparin clumped up all the antithrombin 3. And that's why you got excessive thrombosis if you started the warfarin early on. And the low molecular weight heparin doesn't mop up the antithrombin 3.
Right.
And so you can give your warfarin earlier if you've given a therapeutic dose of low molecular weight heparin. And that's been the understanding.
Okay, but there are, in some other countries, there are also medical reasons why they only start on day one with low heparin, because they are afraid in case they are looking for perhaps malignancy and do coloscopy, that they believe that the patient being then already on warfarin is not the ideal candidate for biopsies and so on. That may also be another reason. But leave it in place as it is, it's fine, as long as you can prevent by this measurement that the patients are on warfarin only. I completely agree, we had underestimated this effect in the past, and now, Dr. Obel, a little blame may also go. We have more cardiologists in the room, maybe also to the cardiologists, because the cardiologists started late, overlapping the initiation of warfarin with low heparin. Has that become routine practice in the cardiology patients when you start warfarin, or don't you use heparin at all?
No, certainly we use heparin because
You overlap.
we overlap. Certainly.
Yeah.
But, it seems to me one of the major reasons that you've got to use heparin is it takes warfarin a bit of time to work.
We still have
And so
cardiologists in Germany who unfortunately don't do it. In particular, our GPs say, well, this patient is now a case for stroke prevention because they have diagnosed atrial fibrillation, and they initiate then the anticoagulant therapy without overlapping. I think it's a mistake. We should do it again in the same way as if you treat a clot. The clot may already be in the heart anyhow, unless you have TE measurement, and some patients have it already. But I'm fine. I'm very glad that you confirmed that for you that is standard of care. So we are starting now educating our people in this regard, and I thought it was standard of care, but I learned from discussions with our people that some said, well, overlapping with heparin, warfarin alone is enough. The pathophysiology is exactly the same. Okay, I'm glad to have consensus. Thanks. Our patient is here. It's Mr. HF. He is at the age of 78 years and is suffering now from calf and popliteal vein thrombosis, which happened 5 weeks after hip fracture surgery. And he has been treated conventionally with heparin and warfarin. However, it is very difficult to keep him in the range of INR between 2 and 3. So the doctor decides to convert him to rivaroxaban. Can also be another new oral anticoagulant because the procedure is about the same. Where can we get guidance? How do you do it? First of all, I think we should spend a moment thinking about the pharmacology. 3 lines are very important. The second line pointing to the fact that the onset of action of all compounds is very fast as it is with low molecular heparin. Elimination half-life is fast, in the same range as well as we have it for the low molecular heparins. That makes it easy then to switch between the low heparins and the new compounds. And here are the differences with regard to renal clearance. The 10A inhibitors have in common that they are less renally cleared, while edoxaban is still half and half. Rivaroxaban 35% active compound, and apixaban 27% renally cleared in the active compound, but dabigatran has a renal clearance of 80%, and we simply need to know about that, not to overlook a potential accumulation with these drugs, simply knowing about it. We also need to know what other medications our patients are taking. Here you have a list for rivaroxaban, pointing to the fact that the compound is not recommended in patients receiving systemic azole antibiotics or some of these HIV protease inhibitors, which have a strong interaction, pharmacological interactions with the transporter and elimination systems, such as SIP system and also PGP, and you have this problem, unfortunately, more frequently than in other countries, and that's why caution is needed to treat the patients then with these new oral anticoagulants. Some of them have the same characteristics as listed here. Others may have a little lesser effect with the HIV protease inhibitors. However, rivaroxaban and other 10A inhibitors have this in common. Care is also to be taken in patients receiving other drugs affecting hemostasis, such as NSAIDs and aspirin or other platelet aggregation inhibitors. Again, this is a common statement because it is well known that any combination of antiplatelet drugs and also the anti-inflammatory drugs increases the bleeding risk when combined with anticoagulant therapy. And at this point, that may be of interest in particular for the cardiologists, I would like to point out that patients receiving dual antiplatelet therapy, perhaps after stent implantation, they have, at least at present time, still a contraindication to receive, here listed for rivaroxaban, the 15 or 20 milligrams once per day. I would say that in general, the evidence is not there for any new oral anticoagulant, that they can be combined, that they can be safely combined in the dose regimen recommended for AF patients on top of dual antiplatelet therapy. Again, I need the cardiologists to comment on this. What are you doing? There's a lot of off-label use also going on in our country. Perhaps lowering the doses of the new oral anticoagulants, but the evidence is not in place so far. Rivaroxaban studies are ongoing to test this and find out the doses being tolerable. We have also negative experience with apixaban. Apixaban is not a bad drug, but it was the wrong dose. It was the same dose as it's given for stroke prevention in AF on top of dual antiplatelet therapy and failed. So we have got some lessons here already. What do the guidelines say? Can the guidelines help us? Guidelines go back to warfarin, lowering the intensity a little bit, trying the landing on the spot, INR between 2 and 2.5. It's not optimal, but that's all I think we can do, unless you have other alternatives in mind. Still real life, isn't it?
I think that what often happens with cardiologists is looking at people who are vasculopaths. The possibility of other bleeds are very important to them. Yeah. And in the absence of a very quick antidote, people feel much more comfortable where they can reverse warfarin quickly. And so the use of the NOACs is down in this particular area because of the population and the need for immediate change. I think should an antidote become available, practice will change. Maybe, but the antidote is then only given in case of bleeding. Yes, but that would be that is the fear. That is the
right,
fear.
But when the bleeding is there, worst case intracerebral bleeding, then the train is gone, and also with an antidote, I'm a little bit afraid that also the antidote may come then quite late. I share your concern, absolutely, and in other cases of bleeding, of course, the antidote is needed. It's work in progress. About the third last slide will point to the fact that we have antidotes in development now, and we hopefully have the clinical results available soon from now. So we are now prepared, at least without stent implantation, to convert our patient to the new oral anticoagulant. And the question is how to do it. It's very easy. Again, where can we seek guidance? There is a very nice paper published by the European Heart Rhythm Association last year, giving us guidance how to convert the patients, for example, from vitamin K antagonist to a new oral anticoagulant. You stop warfarin, and depending on the INR value, you continue measuring the INR values, and depending on the how fast the INR is going down, when it's approaching then 2, you can start then the new oral anticoagulant next day. This is also verbally written in this paper. When the INR is already down to 2, then of course you can start immediately, and if the INR is still high, you simply wait until it's going down. I think that is, you have managed that already in your clinical practice because most of you have already experience with a new oral anticoagulant. So let's stay with our patient for another 4 minutes, for another more minutes. This patient is now on the new compound and suffers from diverticulitis with massive diarrhea. The doctor decides now to put him on a parenteral anticoagulant, and the question is how to do. You simply start when the next dose would have been given. So because of the comparable half-life, comparable pharmacological behavior in this regard, you stop the NOAC today and give the heparin tomorrow, and vice versa. It's very easy. Okay, consensus? So the patient now is back on rivaroxaban, but his creatinine clearance is going down. It's in the range of 39 ml per minute. VTE patient.
So, but I want to just put a spanner in the works because we can actually measure. So we're getting our first results now of measuring rivaroxaban levels 3 hours post. So for us at the Gen, we hopefully will be able to measure it, especially in patients with renal function, get a more accurate level, and for them to decide. And the same for the other patients, you know, when deciding when to stop and when to start, the same as an INR of 2. Hopefully within the next, I'm hoping, we've got our initial runs look good, the next 2-3 months, we would be able to have the right level and be able to then adjust the dose accordingly.
So you do it lab controlled, okay?
I would do it lab controlled, but the guidelines would be between, above 30 would be fine. You could actually not do it. So below 30 you'd start to
Well,
worry.
is it in the labeling? We're talking about a VTE patient. It's not in the labeling. It is in the labeling if this was an AF patient. Why is there a difference? The difference is that in the ROCKET study, it has been prospectively, actively addressed that patients with a creatinine clearance below 50 had to receive the once daily 15 milligrams. In the VTE study, it was not on the study protocol because VTE patients in general have lower comorbidities, don't need so many co-medications, have a lower bleeding profile, lower bleeding risk, and are younger on the average. That's why it was not in the Einstein studies prospectively, actively addressed and implemented in the study protocol. And again, where can we see guidance? Guidance, again, going back to the Heidbüchel paper, the European Heart Journal publication, also for rivaroxaban with a decrease of renal function, the half-life gets a little longer. Most prominently by nature, seen for dabigatran, we discussed that already, that the half-life is getting very long with the renal deterioration. And for the Einstein study program, there is a subgroup analysis in place focusing on the fragile patients, fragility being defined age over 70 years, or creatinine clearance below 50, or body weight below 50 as well. And you see, with regard to the recurrent VTE events, fragile patients have higher frequencies in both groups. However, efficacy was fully maintained with the once daily dose of rivaroxaban. Here in this study, it was 20 milligrams because there was no adaptation. And for major bleeding, again, the safety aspect was fully maintained for the fragile patients, although in general, fragile patients had higher bleeding frequencies with major bleeding. So an option you can take, but it's not a must. So following our patient now, the doctor put the patient on the lower dose. However, now he developed prostate cancer. Cancer and thrombosis and cancer, can the patient still stay on a new oral anticoagulant? What do the guidelines say? And there is a little support also from the subgroup analysis from the Einstein phase 3 development program. Again, cancer patients have higher frequencies of recurrent events, seen here in both groups. However, efficacy was fine, also with rivaroxaban in these patients. Same for major bleeding, as we saw it for the fragiles already. Higher frequencies of major bleeding in both groups. However, if the safety profile fully maintained also for the cancer patient. So this patient, I think, could stay on the new oral anticoagulant. Barry?
Well, there is some data from AJ suggesting that non-coherence might improve long-term survival in cancer patients, and maybe you could argue that.
Maybe you can't argue because the evidence is so weak.
The evidence is weak,
It's
but
really weak.
the evidence is weak, but I'm going to say it's just, I'm just playing devil's advocate.
So that is now our common aim, that we try to prove that for the new oral anticoagulants as well.
But
Let's go for survival in the next study.
yeah, I agree. But survival currently has only been shown with luminoreparin. So maybe
Right.
you could argue that it should be converted to. Maybe. There we go. So maybe you could argue that a low-molecular heparin might improve long-term survival because there is some data, albeit weak.
It's
I
very
agree.
weak data.
No, I'm not fighting with you. I agree it's weak data. But maybe.
But he says the public he doesn't want to fight.
But maybe you could argue that would be a reason why you could switch to low-molecular heparin.
Okay.
And the other point, people, you need to, I think, remember prostate cancer, you need to think about it again. From the patient point of view, if there's a lot of bleeding into the bladder or whatever, then sometimes,
Right.
from a practical point of view, it might be not a good idea to anticoagulate these patients. Because you have difficulties when there's malignancies infiltrating and causing hematuria. And then that becomes a separate, just nursing issue.
Right. But on the other hand, keep in mind that talking about
Yes.
the low-molecular heparin, this also relates to bleeding, and also low-molecular heparin is not a benign drug.
No, I'm not, there will be no anticoagulation.
Yeah.
If the patient's really bleeding. You need
All right,
to-
so the doctor decided to keep the patient on rivaroxaban, and now the patient needs to undergo surgery. He has a diagnosis of prostate cancer. How do we carry the patient through surgery? Would that be different to stay with our low-molecular heparin as if the patient was on low-molecular heparin? No, it's not different. The procedure is the same. Thinking about the pause, no bridging. Okay? Where can we seek guidance? Let's go back to our paper, the European Heart Journal paper, giving guidance when to stop the new oral anticoagulants before a planned surgical intervention. It depends, of course, on the bleeding risk also due to surgery. It depends on the renal function, listed here. Depending on the renal function, in particular for dabigatran, again, the pause before surgery gets longer, in particular in patients with high bleeding risk. Patients with high bleeding risk compared to low bleeding risk have also for the 10A inhibitors a different recommendation. Stop before surgery at least 48 hours, or in low bleeding risk patients, at least 24 hours before surgery. And also in the same paper, a table is listing who is at high bleeding risk, and transurethral prostate resection is among the procedures of high bleeding risk.
But you wouldn't do a two for prostate cancer. You would do a prostatectomy. So you're depending on whether you do a Vinci procedure.
It's the same. The bleeding risk is even higher.
That's what I'm trying to say. So
Yeah,
it's a very high
okay.
bleeding risk.
It's even higher, so it's the same. It's a high bleeding risk patient. And we also condensed that in a recently published cartoon. Patient is undergoing elective surgery. Stop the NOAC before surgery at least 24 to 48 hours, do the procedure, and then the question is when to restart, because you need to counsel your colleagues. The urologist, do we have a urologist among us tonight? Normally they ask your advice. They don't know so much about blood coagulation cascade. So how would you counsel a urologist then when to restart after surgery? When to give the first dose after surgery?
It's not bleeding.
Could you speak loud?
No, it's not obvious bleeding. Surgeon has to decide.
The surgeon has to decide. Okay.
They decide, but at least 8 hours.
Right, right. You're absolutely right. Don't dictate anything to the surgeon.
Yes,
Ask the surgeon about his experience, and when time has come, when the surgeon may say it's adequate hemostasis according to his opinion has been achieved, and then you can start. Don't start before 8 hours after surgery, because under normal circumstances, it will take at least 8 hours to come up with hemostasis. Normally it takes longer. And the urological patients are really bleeding and they have wound oozing afterwards. So it should not be before the next day after surgery. And if the surgeons are in trouble and say, well, I go back to my own experience and I know how to handle the heparins, it's fine as well. They can then start with low heparin as they did it in the past. The only thing they must not do both. So the patients must be stopped then from oral anticoagulation therapy. Unfortunately, we had some miscommunications in some hospitals in Germany where then the nurses ran to the patients with the heparin syringes, put in heparin, and also gave the oral medication. And of course, you see bleeding then. So we can summarize this issue and nail it down to the 3 points. Consider the drug, the patient and the procedure, the half-life of the drug, the route of clearance, coming back to the patient, again, route of clearance, renal function, concomitant drugs, try to stay away from aspirin and other concomitant medications, increasing the bleeding if the cardiological situation allows. And the procedure, consider the bleeding risk. We did that in the past a few moments. And also consider the thrombosis risk due to the procedure. And all this then hopefully will help us to find the balance between thrombosis and bleeding. The patient needs also to be prepared for surgery, and there is no surgeon in the world operating on a patient without having seen an APTT value, a prothrombin time value, normally converted into INR values, and a platelet count. We need to know that these conventional tests may be affected by the new compounds. Any thrombin inhibitor, including dabigatran, has effects on APTT measurements. The 10A inhibitors may have effect on INR measurements. In particular, for rivaroxaban, if you have a very sensitive reagent in this regard, you have a prolongation on INR values. You can do quantitative measurements, as Professor Jacobson said already. You can use the anti-10A tests for the 10A inhibitors or anti-2A tests for thrombin inhibitors. However, in contrast to warfarin, we need to know that these tests are affected also depending on the time when the drugs were taken. So assessment of the NOAC concentrations must be interpreted in relation to the timing of the drug administration in accordance with the pharmacokinetic profile of the drug. So we don't have a steady state over 24 hours. Sometimes we simply forget. We have peak and trough activities either once or twice per day, and that needs to be taken in consideration when you get a lab value. And you need to know that different reagents may produce different results. So, talking now very brief in a nutshell about emergency situations. Our patient perhaps will come up with an emergency situation later on. Then he may also have severe bleeding. The question is what to do. and the recommendation is consider using the prothrombin complex concentrates, as it has also been published and said in the ESC guidelines 2 years ago, that for the NOACs, in case of very severe bleeding, we have PCC in place in each hospital, I think worldwide, and in some hospitals also the Novo 7 is there, but it is not the first option because this is not only very expensive, it also has a prothrombotic potential much more than the prothrombin complex concentrates. So these are the modalities also used for warfarin-induced bleeding. So far, we use the same reversal agents as if the patient came with severe bleeding under warfarin. That is now bringing us close to the end. It has become a race with regard to specific antidotes. These compounds are in development. There is one compound, the andexanet alpha, which is under development to antagonize the action of apixaban, rivaroxaban, and diroxaban. It's a recombinant modified factor Xa inhibitor acting as a factor Xa decoy, very elegant mechanism. Dabigatran will also perhaps have an antidote when it comes to the market after clinical development. This is an antibody-based Fab fragment, which then is only available, can only antagonize dabigatran. And there's a third compound in clinical development, which perhaps will be able to antagonize also the conventional anticoagulants, such as fondaparinux and heparins, including also other thrombin inhibitors and also the direct 10A inhibitors. So this is all work in progress. Perhaps in 2 years from now, we may have antidotes available for clinical use. Let's stay optimistic in this regard. So now it has become a question of cost. Our doctor decided, because of costs, to bring the patient back to warfarin. You may have had the situation already in the past, I don't know how to do it. Last time I'm asking for a volunteer. Patient is on a NOAC. Procedure is the same as if the patient was on Pradaxa or Xarelto. How do you do it? Again, guidance in this paper and a cartoon from my side to underpin it graphically. So you have the patient on the NOAC and the doctor wants to bring the patient back to vitamin K antagonist. You can read this in the paper or you can follow this graph. You started in the same way as if you have the patient for treatment of VTE instead of NOAC, then you had the low molecular heparin. You give both on the same day and measure INR until the INR has reached 2, and then the vitamin K antagonist is doing the job alone. How can you overcome the fact that, for example, rivaroxaban is interfering with the INR measurements? Because this patient is now on rivaroxaban. And if you have a sensitive reagent, you get a mismatch between INR measurement consisting of warfarin action and rivaroxaban action. What is the trick? It's not a trick, it's a common sense. Ask the patient to come for measurement at trough levels. When the patient should come for blood testing before taking the next pill, that means the trough level, to get rid of the unspecific noise on the INR. If you measure then at peak activities, you may get the noise, okay? So, and now, last but not least, the patient is now successfully converted back to warfarin and now has his atrial fibrillation and needs to undergo catheter ablation. Now we are going back to history. We were in the future already, back to history, how to convert the patient, prepare the patient for ablation. I think the procedure, unless you say otherwise, is comparable to surgical interventions. How shall we do that? We need to take the patient across the bridge. Patient is on warfarin. We said that already. Stop warfarin, measure INR, give lumen heparin, and think about the pause. Allow the cardiologist to do the procedure in this time interval and then do it in the other way around. That is the conventional. No? No? How do you do it? Tell me.
Well, there has been, I think that there's now good evidence that during catheter ablation the patient should be fully anticoagulated, and come into the lab fully anticoagulated and not have a big change with heparin on and heparin off, etc. And I think there's very good data to say that they do better, they're less thrombotic episodes that way. Now, there's been some conflicting literature as to whether warfarin should be used.
Simply fade off warfarin and wait?
No.
You continue warfarin?
So the question, what we do in our lab, because I have not been convinced by the literature on the NOACs being equivalent to warfarin in this kind of setting. There have been conflicting papers on that.
Yeah, right.
I change the patients to warfarin before it's done. It's an elective procedure. There's plenty of time to do it. I change the patients to do it, get them onto warfarin when they're well controlled on warfarin, do the procedure on warfarin by using the warfarin, adding the heparin, reversing the heparin at the end of the procedure. The patient is well anticoagulated right through. The question as to the long-term treatment with a NOAC or with warfarin is individualized.
Yeah.
And that's the way we do it.
Yeah.
We do not stop. We do not stop.
Not before the procedure.
We do the
24 hours,
procedure
okay.
on full anticoagulation.
So let's try to find a consensus that then this is the conventional procedure only for prostate cancer surgery or other types of surgeries. But at least I couldn't resist to discuss with you the conventional procedure of bridging, which before surgical procedures is a nightmare, or has been a nightmare with warfarin. But I'm well aware about the conflicting data in the literature and also the discussions. Well, perhaps to do the procedure under warfarin, there are also papers on that. And at least as you have your good experience with what you are doing, it's excellent. And cardiologists need to have their SOPs on the wall how to do it. If it's this way or other way, it's fine. But I couldn't resist talking about bridging and just taking this as a little bit artificial example at the end. So we are at the end, at the final end now, and I would like to summarize and say that the NOACs, in fact, are effective and safe and more convenient than vitamin K antagonists. Is that consensus? Okay, then we have consensus here. Second bullet point, I do hope that we have consensus as well, because I think that it's clinically relevant. However, all anticoagulants, including new and old, carry the risk of bleeding. We are talking about blood thinner therapies, and thereby responsible use is crucial, and this includes careful assessment of the benefit-risk balance, basic knowledge of the pharmacology, we shared this before, knowledge of switching and perioperative pause or bridging, and the knowledge of the bleeding management. And I do hope that I have covered everything tonight. Thank you very much for your time.
Sylvia, thank you so much for giving such useful tidbits for us to take home and to use it from a very practical point of view. Any more questions?
It's over.
Yes, I have another question, and I don't know whether this is the correct forum, but I saw a patient today who is an 83-year-old lady who's reasonably well, but she's hypertensive, big left atrium, sinus node disease, pacemaker, atrial fibrillation. She comes to a CHA2DS2-VASc of 2. The atrial fibrillation was detected on a pacemaker check. She's unaware of it, so we have nothing from the history. And we have an episode of atrial fibrillation lasting 20 seconds.
The question is to anticoagulate
Or not.
or not? You are the specialist for this operation.
And if you
we had
anticoagulate with what?
We had this question with other cardiologists as well. So now you are starting producing more questions than perhaps you can get answers. The question is, how long can AF be to be an indication for AF? And in particular, when it comes also to long-term, the Holter measurements, you detect very short episodes then, and it's an open question, I think, if the patient has otherwise no problems. But I think that is a decision which needs to be made by the cardiologist. Here we can perhaps help you with risk assessment, with risk assessment of bleeding risk and counterbalancing both risk. But I think the 20 seconds just detected by chance.
What did you do?
I haven't made up my mind yet. But I'm influenced, I would be influenced by the height of the CHA2DS2-VASc score. I think if a person had a very high CHA2DS2-VASc score, something like 5, 6, or 7, along those lines, I would anticoagulate with the slightest indication,
Right.
provided I didn't have a big Has-Bled or something like that, which I think I could have.
As your CHA2DS2-VASc scores, but your Has-Bled goes up.
Yes,
Unfortunately.
the two go hand in
But
hand.
I just
Go
got-
hand in hand. You never get a high CHA2 and a low Has-Bled. That would be great.
Yeah.
Unfortunately, as the CHA2DS2
The two are
goes
the
up,
same.
the Has-Bled
Yeah.
goes up as well.
Nevertheless, nevertheless, I would then do that. I would be more influenced if I was uncertain, again, by the availability of an antidote.
I think that's a very valid point.
Well, Dr. Oberl, I'm a bit scared because you started saying that the patient has hypertension. How well controlled is hypertension? Hypertension is one of the major risk factors also for bleeding. And if hypertensive patients bleed, they unfortunately quite frequently bleed into the brain. And in brain bleeding, I started saying that already in the beginning, the antidote may also come late. We feel uncomfortable, see the patient, do it individually, and also discuss it with the patient. If the patient gets a dictate from the cardiologist to come up with blood thinner therapy, and the patient does feel uncomfortable, we will also produce non-compliant patients. So I think it would be a common decision. And if I can't seek help from my surrounding, I will go to ask myself, if I was in this situation, would I want to have a blood thinner therapy or not? So it is individual. We cannot come to a common conclusion now, and perhaps we can have a glass of wine and share more experience, but that is also not the best solution. Are there other questions from
Any
other
questions?
colleagues?
Dave? Dave? Yes.
So the biggest hurdle is the funding issue. In the rest of the world, are you guys getting as much resistance to change as we're getting here?
So in the funding,
Funding,
yeah?
Funding. Is funding a problem?
Yeah.
Medical funding.
Of
Do you have
course,
a
funding.
problem in Germany?
Well, we have a
You've got
saying-
euros, we've got rands. It's much cheaper there.
Yeah. Well, the insurances ask us to try first the conventional vitamin K antagonist, but that is wishful thinking. So our cardiologists go straight away and prescribe the NUACs, and so far we have not got reimbursement problems. They are quite generous. We have some reluctant doctors as well. They want to see the evidence after 10 years. But I think, well, in medicine is a conservative discipline. But unfortunately, there are some doctors who are still a bit reluctant using the new oral anticoagulants, but this is the absolute minority. So funding the bottom line is not that much an issue in our country. And I know that you are also forced to try warfarin first, and when you fail with regard to instability of INR or other issues, then you are allowed. But it would be a nightmare if you fail with catastrophes, because then the train is gone and you may talk about secondary prevention for stroke instead of primary prevention. So I think it's difficult to discuss these issues also with the patients. We are talking about informed patients. We need to make the patients compliant and talk to them and offering them two alternatives. One alternative saying, here you have a drug which is now in place for many, let's say half a century. However, it produces a little bit more brain bleeding. And we have another option where exactly this type of bleeding has been markedly reduced. Is that a fair discussion with the patient? I think it's unfair.
Then they have to cover the cost.
Then they have to cover the cost. I mean, the problem is that whether the funders can afford it, which is a separate issue.
Then they use
But,
the word protocols.
Beg your pardon?
According to the protocols.
Yeah, according to the
That
protocols.
is the famous word, the buzzword.
Thanks, Dave. Any other questions? Yes.
I just want to find out, I do dialysis and I do have problems with patients with thrombocytopenia. And then to anticoagulate these fellows, obviously they all bleed. If you don't anticoagulate them, unfortunately they do clot despite the low platelets. So the approach to that, in terms of anticoagulating them.
The narrow.
Sorry, the cause of the patient's thrombocytopenia and dialysis is TTP?
Yeah, some of them will have probably DIC and they had renal failure.
Well, in DIC patient, it is a nightmare to talk about full anticoagulation. And these are patients who had been very difficult to manage in the era of conventional anticoagulants, and they remain a nightmare for us in the future, also with the new anticoagulants. They don't help us at all in this scenario, to be honest.
Yeah.
There's been some noise made, by Harry.
Sorry, but we can't hear
Sorry, just
you.
one, just tell
That's
it.
okay.
Yes.
There's been some noise made by Harry Bueller when he was here recently about giving low molecular weight heparin with rivaroxaban prior to rivaroxaban onset. And he felt this was a good idea. It made the physician comfortable, but also that maybe, although the rivaroxaban trials were not with low molecular weight heparin, whereas the Dabigatran was with low molecular weight heparin. What do you feel about that?
Well,
I mean,
just to clarify that, I mean, because the Einstein P, what they tried, and they haven't done a subgroup analysis, that a lot of the patients from a logistic point of view had received low-molecular heparin by the time they had gone onto the study. And the same thing for the edoxaban group. And that was the question that Harry brought up in debate at our meeting, was perhaps low-molecular heparin was a good option to start and then to switch over because of the fact that the Einstein and the Einstein P both had a group. That was what he was trying to say. So,
Well, but I think it's good that you bring this question up, because we should discuss another scenario where perhaps the patient is in hospital, is now, let's say, a week on low molecular heparin. And the question is, if then the decision is made to take the patient to rivaroxaban, do you need to start?
but I don't think that's not the question. The question
No, the
is...
question was different, but we
Okay.
have answered the question
Okay.
already. But I wanted to extend the
Okay,
question
all
into
right.
clinical practice. There may be patients
Yes.
who are a little longer than just 1 or 2 days on low heparin. If they have 1 or 2 days, Einstein protocol was go for
Yeah.
the 3 weeks. But my concern is, and that may happen not with rivaroxaban, but it may happen, for example, for the dabigatran or the rivaroxaban to come, if the patients are then only very few days on low heparin and are taken to the maintenance dose of the new compound too early, I will have my concern. And if it is a patient who is maybe on, let's say, 4 days on nolpepirine and you want to convert him to rivaroxaban, do you need to fill up the 3 weeks? Or do you have another 3 weeks on top of that? Or just, can you go to the maintenance dose? And here we have a little gray zone. Here we need to use our brains, common sense, and it's not a dogma that another 3 weeks must be done. You can also fill up until 3 weeks. If it was a calf-ring thrombosis, I would see that different and say, well, if it was a PE, I would of course go for what is the evidence. And we have seen in a separate PE study how strong this intensified treatment was and how safe it was. So that makes me so confident. We haven't seen more bleeding, and then of course I wouldn't even fill up only up to 3 weeks. I would give them the full 3 weeks on top of 4 days before the nolpepirine. You can't make a mistake.
Good question, thank you. Any other questions? Yes.
As a GP, how long would you keep the patient for a DVT on NOAC for? How long? How many months to keep them on?
Well, that's a good question, and brings us again together with a glass of wine because it's a long answer.
It depends, it's a long answer.
It depends only on a few things. First, don't do it different as you have done before. You may have some algorithms in mind how you have treated the patients before. We are inclined as clinicians to go for longer anticoagulation as we may find it in the guidelines, because we now have seen also in contemporary studies for all compounds, as soon as you stop, you have a new onset of recurrent rates. However, we also have learned that there is no lunch for free. We also see some bleedings. When compared to warfarin, we see less bleedings. However, we will continue to see bleedings. So the question is, we have safer drugs, but we could not come up at present and say go for lifelong treatment. So we need to find an algorithm depending on either the dimer measurement. If you want to do it, I'm not inclined to do that in all of my patients. I go much more for doing another ultrasound in the DVT patients to see how the thrombus behaved and if it's still there, to discuss with the patient if I will counsel them to stop or not to stop.
It's published in our guidelines.
And other risk factors as well. So there are some algorithms in there.
If you wean them, how long do you take over weaning them off?
There's weaning. There's no weaning. There's no
Just stop, zap, stop.
You never wean. No weaning, just stop.
Yeah, that's right.
Just stop. And the last question, yes.
Just want to find out with protein C, protein S deficiency,
Yes.
what does you prefer?
You can give the new oral anticoagulants as you had treated the patients so far with conventional anticoagulants.
Except that the protein S has been caused by HIV, because then you have to alter the dose.
Okay, yeah, very good point. And keep in mind, please, if you go for functional testing of protein C and protein S, you may interfere with the test systems using the new compounds. Keep that in mind. You can do genetic testing for any thrombophilias, but the functional testings may interfere with the test system.